Hi, everyone. My name is Carissa Little, and I am one of the account managers here at USDTL. Thank you all for joining us today for another installment of Talks Time. And if you are new to our Talks Time, we welcome you. Today's presentation topic is about protecting your hospital with forensic newborn drug testing. And presenting today, we have Dr. Joseph Jones, Chief Operating Officer here at USDTL. We also have Kiabeth Santos, our newborn team supervisor, who will be the moderator for today's event. As a reminder, if you have any questions, please submit them in the Q&A section at any time during the session. And of course, at the end, we will open up the platform to answer any questions that you may have submitted. We have a lot of valuable information on today's topic, so we will be recording today's presentation. We'll be sending the recording to all registrants to view for future use. All right, so let's get started with our great presentation today. We now welcome Dr. Joseph Jones to discuss how forensic newborn drug testing can protect your hospital. Enjoy the presentation. Thanks. Bye-bye.
Thank you, and welcome to this version of ToxTime. My name is Joseph Jones, Chief Operating Officer here at USDTL. Let's get started. Today, we'll be talking about protecting your hospital with forensic newborn toxicology. What exactly does this mean, and what risk could be there if this is not thought through? As we begin here today, I would like to start us out with a survey question. The question is does your hospital initiate chain of custody when collecting a newborn specimen for toxicological analysis? If we could take just a few moments and answer yes or no, that will help guide the remainder of our discussion today. So why is a newborn toxicology specimen a forensic specimen as opposed to a clinical specimen? Two things: the nature of the specimen and the reason the case was selected for testing. The nature of these specimens is that they're once in a lifetime specimen. So going back for a recollection, well, in the case of meconium or euchroid, it's just not even there. For other specimen types, the detection windows are short enough that these are snapshots in time, and you're not going to get the same information. Many clinical tests, if you collect it this morning or this afternoon, you're going to get the same result. For instance, a hemoglobin A1C, if you collect that today or tomorrow, there's not going to be that much difference. But a urine specimen for the detection of marijuana or cocaine, it could be positive today and negative tomorrow. The reason for the testing is, by and large, we have an elevated suspicion of prenatal drug exposure. Newborn toxicology is a very expensive endeavor because of the types of specimens and the types of processing that the lab has to do in order to detect drugs of abuse. So they only can select certain samples to send in as opposed to sending everybody. We have a number of policies from different hospitals that have allowed us and given us permission to share them. They all look different, they're formatted differently, and they're verbalized in different ways. But if you read through them, there are a lot of consistent themes that show up in these policies that make sense with regard to newborn toxicology. First, is there an altered mental state, especially for the mother, sometimes even for the father in the policy? Was there a previous history? Was there abruptio placenta? Is there a positive maternal urine on arrival at the hospital? Was there insufficient prenatal care? And are there signs of withdrawal? These different themes show up in a lot of different policies. Yours probably looks a little different, but it has a lot of the same concepts here. So these populations that we choose to test for newborn toxicology are an enriched population. What does this mean? This means that when the sample is selected for testing, there is an elevated suspicion of prenatal drug exposure. That means that of the samples that are sent to the laboratory, there is a very high probability that a drug is going to be discovered. When that is reported back, most jurisdictions have some degree or level of mandatory reporting. And so at that point, when this sample is selected for testing, you're actually becoming a state actor. And at the very beginning, you know it's got a good chance of being positive. When it comes back, it's got to be reported. And you know that in certain circumstances, actions are going to be taken. So it is imperative on your part to treat this sample as it has a high probability of being litigated. Therefore, it's forensic. Okay, so now we've talked about, is the sample forensic or clinical? Well, what's the big difference? What makes forensic processes different than clinical processes? There are two cornerstone concepts for the production of a defensible forensic toxicology result. The first concept is screen and confirm. The second concept is chain of custody. So what does screen and confirm mean? Well, this was a concept that has its origins almost 200 years ago. Matthew Orfila, who is considered by many to be the father of forensic toxicology, was involved in a very high publicity criminal case in Paris. One of the concepts that Orfila put forward was that the presence of a poison must be proved in the blood and the organs before it can be considered the cause of death. Now, this is slightly different than what we talk about today with two different instruments, but it's the same concept of screen and confirm. So why is it an advantage? Well, it minimizes errors and sample switching for one. Since we can't recollect these once in a lifetime specimens, it's very, very important that we get the right answer the first time. So the theory is that if you have an aliquot A, an aliquot is a portion of a specimen used for testing, and you have a team, we'll call them team A, and they do the screen test and they get a specific result. So we go back to the original specimen, we get an aliquot, and we'll call it aliquot B, and we're going to test it using team B, using a different technology, and if it doesn't agree, that means that somewhere along the way an error was made. Accuracy is improved by using two different methodologies. So the theory is that if you have a screen methodology and a confirm methodology, if you get a result on the screen methodology that matches the result on the confirmation methodology, that you have now analytically improved the accuracy by orders of magnitude. It also dramatically increases speed and lowers cost. In today's world, we can do a screen test that is very rapid so that you can get your negative back quickly and everyone can move on about their life. And then we can focus on a more expensive, more sophisticated process to do the confirmation so we can increase the speed and lower the costs. In today's world, this generally involves some sort of an immunoassay initial test with confirmation using some sort of a mass spectrometric test. Now here in this image, I have an image of an ELISA immunoassay test, and I have an image of a GCMS instrument. So what exactly is chain of custody? Well, simply said, it's a document that depicts who had possession of the sample, when they had possession of the sample, and the reason or the purpose that they had possession of the sample. Now, this is a document, and it is technically hearsay evidence because it is secondhand information. But there are certain pieces of hearsay evidence that are allowed in litigation. And one of the pieces of hearsay evidence that is allowed is called a normal daily business record. If you keep chain of custody on your samples as a normal daily business record practice, then it is allowed as hearsay evidence. And what this does is it avoids the need for firsthand testimony. If you do not have a procedure for documenting chain of custody, that means that you could be subpoenaed to come in and provide firsthand testimony about a sample that you did months to maybe even years ago. And that would be very unnecessary. So what does the College of American Pathologists require? In the forensic drug testing checklist, they note that the receiving and/or accessioning procedure requires a record of verification of, number one, the specimen identification adequacy. In other words, is there enough information on the specimen or the paperwork with the specimen that can positively identify the donor of the specimen, who collected the specimen, and when? Number two, is the specimen security seal condition or secured specimen container integrity intact? That means that is there a way that the laboratory can verify that the sample container has not been opened and either sample taken out or stuff put in? Is the security seal intact? Most collection supply kits will have a tamper evident seal, and that's the purpose of that seal. Number three, the external chain of custody completeness upon receipt. And so this says that the laboratory is responsible for making sure that the chain of custody for a sample that we report out, internal and external, the chain of custody has to be complete. An additional requirement of the College of American Pathologists states that the external and internal chain of custody records are available and properly completed when we're going through our inspections at our laboratory. And so what they mean by internal versus external, internal is the chain of custody that we do in our laboratory. External is the chain of custody that happens outside of the laboratory, so at the collection site and through the courier, FedEx if you will, and into the laboratory. One strategy that I keep hearing about is the strategy that at the collection site, chain of custody is not being initiated, and that the forensic laboratory is claiming forensic analysis because they're saying that when we receive it at the laboratory, well, we start the chain of custody, therefore it is a forensic analysis. As you can see from this checklist item, that does not hold up because the checklist item dictates that we have to determine that the external and internal chain of custody records are available and are properly completed. Another thought that I've heard over the years is, gosh, we just don't want to do chain of custody because, oh my God, you got paperwork and signing this and signing that. Just relax. Chain of custody is simple. It's not a big deal. It can be as simple as a signature and a date and then the application of the tamper evidence seal. It can be that simple, or you can complicate it, but it can be just this simple. As we mentioned at the beginning, we're going to cover a couple of case studies that I have been involved with over the past few years that can kind of shed some light on some of the risks that can be the result of not thinking through the whole notion of forensic testing versus clinical testing. The first concept we should talk about is whose specimen are we going to use? So I mentioned this in a previous ToxTime, but early on, maternal urine was a logical choice for detecting prenatal exposure. As the labs back in the 80s were gaining access to automated platforms to do immunoassay in a really high throughput, really efficient, inexpensive manner, we were able to use these really robust GCMS platforms that started making themselves available in the mid to late 80s. So there was a lot of high throughput workplace laboratories in the country, and people were learning how to use these strategies. So they became available to hospitals, and they were practical and they're very cost effective. So some of the first strategies of detecting prenatal drug exposure was using a maternal urine sample. Made sense at the time. But then one of the issues that came up early on was that, if you're using mother specimen, you need to get her consent. And what the Supreme Court of the U.S. decided in Ferguson versus Charleston was that by using mother's urine, you're indisputably searching within the meaning of the Fourth Amendment. So mom has Fourth Amendment rights. And if mom is a drug user, she's clearly not going to give you permission to test her specimen in a forensic manner. And so on this, using a newborn specimen was kind of the result of this conversation, in that the newborn was the patient, and it is in the best interest of the healthcare professional to act in the best interest of the newborn. And so the newborn specimens are the specimens that should be used if we're talking about looking for prenatal drug exposure in a newborn. So back in the mid-90s, there was a case in Kentucky that went as follows. We had a case where there was 23 prenatal visits, so that's good. Mom had gestational diabetes, not so good. Unfortunately, there was a lengthy labor that ended with cesarean section, and before it was over, there was ruptured membranes. There was meconium staining. There was meconium aspiration. And the meconium was collected a few hours following the birth, and according to their in-house procedure, the specimen was forwarded for analysis, and that specimen ended up being positive for cocaine and metabolites. In this particular instance, chain of custody was not initiated. The staff decided that they wanted to avoid testimony by avoiding the thought that these were forensic specimens and they were simple clinical specimens. The specimen, as I mentioned before, was positive for cocaine and metabolites, and the family disputed the results. They're like, no way that can be positive for cocaine. So unfortunately for the staff, without a documented chain of custody, testimony was required. And so all the nurses on the staff had to go in and provide testimony, depositions, the whole 9 yards. Now this case lasted 12 years. Let me say that again. It lasted 12 years. They thought they had an outcome at about 4, 5, 6 years into the case. And at some point during that timeline, one of the individuals on the staff altered their testimony a bit such that it initiated an appeal. And that appeal was appealed, and it went all the way up to the Kentucky Supreme Court. So 12 years later, we finally get a result. This is a quote that comes out of the decision from the Kentucky Supreme Court. Quote, "There is no documentation in her medical records of such a sample being taken. However, there is a sworn testimony in the record by employee X that a patient care assistant that was handed a sample by nurse Y on the evening of baby Z's birth and told to label the sample as belonging to baby Z and send it to the in-house laboratory to be tested. She also testified that a resident physician verbally ordered the meconium drug screen on baby Z." So here we have a lot of verbal stuff going on. You got someone with a sample in their hand. Maybe it's identified properly, maybe not. We don't know. We don't know what initiated the test. Why was the test being ordered? We just have that a resident physician verbally ordered the test. And then we've got the sample being handed from one person to another person with no documentation. And if you think about with the meconium, these tend to be multiple collections that are added together before they're finally sent off. And so we just got a complete breakdown in the chain of custody on this sample. So we'll never know if the laboratory got the right sample for testing or not because there was no chain of custody. Had there been a documented chain of custody, this could have been resolved right away. And it would have not have taken 12 years. It would have taken more like 12 weeks because we could have gone back, reviewed the chain of custody. We could have sent the specimen out for retesting or retested it in-house. But either way, we could have avoided a lot of this discomfort. 12 years is a long time. Here's a case that's going on right now in the state of Maryland. There was a newborn selected for toxicology, no chain of custody, no confirmation testing. The meconium was positive by immunoassay only for opiates. Now, it turns out that mom was administered morphine during labor and delivery. A local expert who is not an expert in forensic toxicology, but is plugged in locally, claimed that that positive opiate result could only be due to the mom using heroin. In this particular case, mom is fighting for her parental rights. I was in discussions with the consultant for the mom. Now, of course, I don't know all this information about this case, but as it stands here, without confirmation analysis, we don't know if it was a low-level morphine due to mom being given morphine by the hospital, or if it was hydrocodone or hydromorphone or oxycodone, or is there heroin metabolites in there as well? Without the confirmation test, we don't know this. And so in this particular case, I do expect an appeal. Here's another case about the Mother Risk Laboratory up in Canada. I know it's not the US, it's up in Canada, but a lot of things process the same way up there as they do down here. Now, as I mentioned before, the CAP-FDT program has these strict guidelines concerning chain of custody. So a lab may say, oh, well, wait a minute. We're not CAP-FDT, we're clinical. This is kind of a similar situation that happened with the Mother Risk Lab. So we had a laboratory. It was a great laboratory. Lots of published data concerning prenatal drug exposure and FASD. A storied organization with decades of really great literature in the scientific literature. But they were operating without forensic oversight. A couple of years ago, one case unraveled a long list of deficiencies because they were operating without forensic oversight. Now, what does that mean? So if you are a forensic laboratory, that's because you are accredited by a number of agencies, one or many. And so like for our laboratory, not only do we have the College of American Pathologists inspection every other year, just like your hospital labs, but we also get inspected by the College of American Pathologists Forensic Drug Testing Program. And they come in specifically to provide oversight of the way we handle our specimens forensically. We also have a certificate from the New York State Department of Health, which has a specific forensic toxicology certificate. We are also accredited by the ISO 17025, specifically for forensic laboratories. So over a 2-year period, we have 3 different agencies that have forensic experience coming in, providing us with forensic oversight. Hey, Joe, you shouldn't be doing that. Hey, Joe, you need to be doing this, or this could be done better. Or, hey, this is great, continue, and off we go. Forensic oversight. So in the case of this lab in Canada, that one case, the more they looked, the worse it got. And it unraveled a huge list of deficiencies. It was a huge PR issue for the hospital and the University of Toronto. And the Honorable Susan B. Long wrote an extensive report that was published at the request of the Ontario Ministry of the Attorney General. And the result of all of this is that thousands of cases had to be reevaluated. Thousands of cases needed to be reevaluated. Think what that would mean for your organization if you had to go back 10 years and reevaluate all of the cases that you had to report back to social services. It'd be a huge PR issue for your department and for your organization. So hopefully not to end on the negative note of the previous slide. USDTL, we are on a mission to make a difference, and we're here to help you. And so we have a number of infographics, we have a number of posters, we have a number of news articles that are on our website. They're free to you to pull down and use. We are also available to talk to you about your testing options and what are available to you, and to talk you through how we do the screening and how we do the confirmation. We're also available to help you understand, what's the minimal requirements to establish chain of custody, or to make sure that your chain of custody is intact for your littlest patients. How do you order the test? How do you start the chain of custody? We're available to help train your staff on how to do that. And if you're not sending specimens to USDTL, we're also available to help you set up an account so that you can send them to our laboratory. I hope you enjoyed our presentation today, and we are now available for questions. Take it away.
Great presentation today. Thank you so much, Dr. Jones. At this time, we would like to open the platform for any questions you may have. If you happen to not see the Q&A section, please click on the three dots on the lower right side of your screen and select Q&A. While we get the questions rolling in, I wanted to let everyone know that we will be sending a recording of this event to everyone that registered. And for those of you that attended the live event, you will receive a certificate of completion shortly after the webinar. As questions start coming in, we would like you to answer a poll and appreciate your feedback. I understand you may have many questions regarding completing this chain of custody form, which is honestly so fast and easy. I would love to have the opportunity to walk you through the process and address any questions you may have. So with that, are you interested in attending a brief educational webinar on completing the chain of custody? Yes or no? If you happen to express interest, a member of our team will reach out to you directly to schedule training. Dr. Jones, a question did come through. Do you accept specimens without chain of custody?
At our laboratory, we do not. And so we decided several years ago that this type of work was, you know, the repercussions are just too much. And I know we've walked away from a lot of business over the years, but that was a decision that we made. So every specimen that comes to our laboratory, there has to be a chain of custody with it, and there has to be a tamper evidence seal. And that's kind of where we stand on it.
Thank you. Another question that came in. Does every person handling the specimen, including the courier, need to sign off on chain of custody?
Yeah, that's a good question. And so that's the beauty of using the tamper evidence seal. So when you have the collector, or in the case of like a meconium, the final processor, once they put the tamper evidence seal over the top of the sample, that seal is designed such that if you try to open it, it will either tear, break, or become unsealed, and you can't stick it back. And so it's obvious upon receipt that it's been tampered with, hence the name tamper evidence seal. So once the collector puts the tamper evidence seal on the sample, they put it in the bag. When it ships to the laboratory, sometimes those samples don't come straight to the laboratory. They can take a tour around the country first, and they'll come back and you'll see forklift wheel marks on the bag and all of that. But the important thing is that when we receive it, when we get the specimen container, so like a cup with the Euchlid meconium or even an envelope with the hair, if that tamper evidence seal is intact, then we know that that's the same sample that's in the same, from that same donor as when the collector put the seal on it. And so it's protected during that time. And so all of the different people that are involved in the courier, once it's sealed, we don't need to know who they are, just so it gets to the laboratory with that seal intact. So good question. Thank you for that.
Thank you. Another question just came through. It says, how long do records of chain of custody need to be kept per cap?
Per cap, the last checklist that I'm familiar with is 2 years, but at our laboratory, we are also accredited by the state of New York. And several years ago, they upped theirs to 7 years. And so at our laboratory, and we didn't want to pick out who's New York and who's not. Plus, when some of the samples come like through another major reference lab, we really don't know where it originated at. So we pretend that it could come from New York. So we decided several years ago that we'll just keep all the data, all the chain of custody for 7 years. And then after that, it's gone.
Thank you. Another question that came through is, does your laboratory release preliminary results?
On a case-by-case basis. So at our lab, our goal is to get these results to you as quickly as possible. So we put a lot of effort and resources into getting that screen out the same day that we receive it if it's all negative. And if it's presumptive positive, we do our very, very best to get that sample out the next day. So hopefully you get the result before you need to know what the prelim result in. But there are cases where maybe we have to reanalyze it, or it was maybe really, really high and we have to like send it through with less sample. So on a case-by-case basis, we can send you what's called a pending report, and shoot an email or a phone call to client services, ask them for a pending report, and we'll shoot it out. And it will have all of the results that are ready will be on there. And then the one that we're waiting on will say pending. And so we can do that on a case-by-case basis.
Thank you. Just to remind everyone, you can continue to submit questions in the Q&A section on the bottom right side of the screen. We have another question that came through. If we don't get a result within 24 hours, does it mean it's positive?
It's a clue, but it doesn't mean it's positive. This is why we have to confirm samples. If we knew that already, we wouldn't have to confirm it, right? So, but if we have a sample, and if you're looking in your web portal and you can see that we did receive it and it's been 24 hours, odds are if you don't have that report back, it's going in for confirmation. Now, confirmations confirm negative all the time. Not many times, but it's all the time. And then in the case of something like opiates, well, you know, which one is it? So it can give you an indication if you're expecting it's going to be positive for something and it's taken over a day to get results back. It's probably going to be positive for something, but we can't work with probably. So shoot an email to client services or give them a call. They'll be happy to shoot you a pending report, and you can see if that's kind of what you're expecting.
Thank you for that, Dr. Jones. I don't see any more questions coming through. I'll give it a few more seconds to see if anything comes through. In the interim, we have another poll for the audience today. After today's webinar, did your thought process change regarding the importance of forensic newborn drug testing? We appreciate your participation. One question did come through, Dr. Jones. Do you test for fentanyl?
Yes. We've developed and validated a fentanyl test in umbilical cord and meconium a couple of years ago. And we actually have a couple of papers on that. If you would like a copy of the papers concerning fentanyl and umbilical cord, you can shoot an email to either myself or Kia Beth, newborn at USD, whichever email you have in your address book, and I will be glad to share that. We have some posters, and so we've really presented a lot of that data. There's not a lot of data out there with regard to prenatal fentanyl exposure, and as we all know, fentanyl is a very, very important medication for pain management, and especially, you know, in labor and delivery, it's very important. And so the more we know about this, the better off we'll be. Now, there's plenty of papers about blood levels of fentanyl on the babies following C-sections or other procedures where fentanyl delivered at the hospital for labor and delivery reasons. The evidence is really clear that there's no apparent long-term negative health consequence on that. It's the fentanyl that's long-term prenatal that we should be concerned about. A lot of our drug supply in this country is contaminated with fentanyl. We have a lot of new and novel compounds coming out all the time. Sometimes they're laced with fentanyl. And so even though we're not testing for some new bizarre compound that's coming out of China, if it's laced with fentanyl, at least we get that information and we can get an idea of what's going on there. So fentanyl is a very, very important compound. It's becoming even more important in the field of newborn toxicology. And if you're not testing for it, you're not going to find it. So I would urge you to talk to your client service rep and make sure that fentanyl is on your program, because it's not going away anytime soon. And if you're not testing for it, you're not going to know about it.
Thank you, Dr. Jones. Someone did request clarification on the turnaround time. They said you
Sure.
mentioned earlier a 24-hour time frame. Can you expand on our turnaround time?
Yeah. Well, in the frame of never say never, unless you're saying always never say never. And so our goal is that the turnaround time for screen negatives is 24 hours, and we require 1 or 2 days for the confirmations. And as one of the graphics while you were waiting to watch this, we pride ourselves on the fact that we beat that 99% of the time. And like I said, we put a lot of resources towards that, because, you know, we understand that these cases, we can't do them. They need the results right now as quickly as possible. Occasionally you will have that sample that just doesn't behave, and maybe it needs to be screened again. Something was wrong with the screen result. Maybe there's an interfering peak on the confirmation, or maybe there's just so much in there we have to dilute it and send it back through. And so sometimes you'll have that sample that we all hear about that takes 5 or 7 days to get it out of here. But fortunately, those are not the norm. 99% of the time we do hit our turnaround times, and we're really proud of that.
Thank you, Dr. Jones. Another question came through. It seems that the bad guys work hard to stay ahead of the lawmaking process. What tests are available for drugs such as cathinone, synthetic cannabinoids, etc.? Are the bad guys staying ahead of the ability to test?
You know, that's a very, very good question. And this came up, I was at a conference earlier this week in Albuquerque called the National Organization for Alternative Programs, and this question came up. And so and this is what we're talking about with these novel compounds, and they're coming up all the time. So if you come up with a panel of synthetic cannabinoids, inside of a year or two, that panel is obsolete and they've moved on to something else. And the regulatory environment is such that it's a very involved endeavor to get a new compound to market from the lab testing perspective. And sometimes by the time you get there, the compound's gone. And so it's a huge challenge. It would be really nice if there was a way to keep up with that challenge and still be scientifically responsible. We know that the Chinese chemists that are sending this stuff over here and the Mexican chemists across the border, we know that they're not worried about scientific responsibility, just based on the danger of the really seriousness of some of these compounds that they're selling to the public. So lucky though, lucky for us, not them, lucky for us is that the vast majority of the drug abuse is from the same old stuff. And so the order of magnitude of metham cocaine, heroin, and of course now fentanyl has kind of joined that group now. A couple of orders of magnitude more prevalent than those isolated like some of these really rare cathinones that you will hear about. They're sensational because it's brand new, and you know, mailman bites dog gets front page, but dog bites mailman. Nobody's really interested in that. And so the good thing for us is that people tend to gravitate back to the drug of their choice. And so if they're using these synthetic cannabinoids, for example, great paper from an acquaintance of mine over in Italy, Alberto Salamoni. He published a paper several years ago where they were screening a large number of Italians for these exotic synthetic cannabinoids. And what he found was that in hair, every one of those samples, every one of them in his group, every one of them that was positive for one of these rare synthetic cannabinoids was also positive for marijuana. So what's the takeaway on that? Is that when you're testing a short detection window specimen type like urine, someone can quit for 3 days and white knuckle through. And if you can't quite white knuckle through, you can maybe do some spice or K2 and make your way through those 3 to 5 days until you can pass your urine test. But over a 3-month period of time, everybody likes their weed. And so they might use the synthetic cannabinoid for a few days and hee ha ha, I passed my urine test. But over a 3-month period of time, they're going to gravitate back to the drug of their choice. And so this is especially with a long-term test specimen type like hair, fingernails, meconium, and umbilical cord, we get a lot of substance positives because over that long period of time, you've just got a lot more opportunity for them to take a whole bunch of different things. Whereas a urine, maybe they're just taking their prescription Adderall prior to dropping the urine. So interesting question. And so lucky for us as administrators and laboratories, the same old stuff is going to show up. And so those really super novel compounds, while interesting, right now are way too expensive and impractical to target. And so we have to move forward with what we have.
Thank you, Dr. Jones, for that great explanation. So we're coming to an end. I don't see any additional questions coming through. So with that, I would like to thank you, Dr. Jones, for your time today and for presenting and answering our audience's questions. And for our attendees, as a reminder, we are exhibiting at the A1 convention this coming June. Also, the New York Perinatal Association Conference, the AAP Section 8 Conference, and many more. If you're attending any one of these conferences, please stop by the booth and say hello, or feel free to reach out to us prior to the conference so we can set up a date and time so that we can connect or grab lunch and meet with you. We would love to hear your feedback about this event by completing the survey shortly after today's webinar. And of course, to keep up with the latest events, we encourage you to visit our website and join our mailing list. Also, feel free to connect with us individually and our business as well on LinkedIn, Facebook, YouTube, or Twitter. We hope everyone enjoyed today's presentation. Thank you again for joining us and have a great day. Bye.
Subscribe to our channel to see more videos like this.